Bismillahirrahmanirrahim. My today's presentation is on the post-polio deformities and residual paralysis, especially on the upper limb reconstruction surgery part 3. I have the experts with me, Professor Mehtab Birwani from Karachi, Professor Shoaib Khan from the Peshawar, and Professor Imtiaz Hashmi from the Ziauddin University, Karachi. I have previously discussed that before embarking to any reconstructive surgery, it is necessary to have a detailed understanding and knowledge of pathological processes, pathoanatomy of deformity, clinical assessment meticulously, reconstructive procedure principles, regional deformities and management principles. I have discussed in detail in the previous two lectures. During the decision making, there are certain factors, and the most important factor which needs attention is the age of the patient, functional assessment of the limb and spine, socio-economic background of the patient, and the radiological examination to know the subluxation, dislocation, and the deformities of the bone as well. We have also discussed the functional assessment to be done with the muscle charting, power grading of the muscles, extent of the contractures and the deformity the patient having, ambulatory status and the posture patient is adopting, and any limb length discrepancy. This is available in my previous two lectures, in part 1 and part 2 lectures. Then, to know about the extent of contractures, one should do the following tests. That is the Trendelenburg test, Thomas test, Ober-Jan test, ankle and foot deformity evaluation and muscle powers, pelvic and spinal curvatures. We have already covered these in the part 1 and part 2 lectures and my previous lectures on the cerebral palsy decision making that are available on the slide share and the YouTube. We have also discussed the ambulatory status, how to know. We can do the observation gait analysis with the camera. We can do that in the gait laboratory. Then abductor lurch, extensor lurch, which can be because of the gluteus medius and gluteus maximus, hand-knee gait because of the paralysis of the quadriceps femoris muscle, and the calcaneus gait, which is very difficult to treat when there is a paralysis of the triceps suri. There may be a foot drop by the extensors of the dorsiflexors of the ankle joint, and there may be a short limb gait. We have given this in the detail in the gait analysis and the gait disorders lecture, which is available on the slide share and the YouTube. We should also know the prognostic factor before embarking to surgery, that if there is a severe initial paralysis, diffuseness of its regional distribution of the paralysis and the deformities, patient and parents' expectation and the support available to the patient, and the resource availability. In general, it is said, if there is a more extensive the paralysis in the first 10 days of illness, there is more severe ultimate disability. We have also discussed in lecture 2 regarding the reconstructive surgery principles, which may be in early stage the fasciotomy, capsulotomies, then the re-establishment of the power with tendon transfers to prevent the deformities, and the muscle transposition to replace the muscle power. If the joints are the flail, are weak and subluxated, we can do the tenodesis like this, and the construction of the bone block in the foot drop. We can do the correction of the deformities should be corrected before embarking to tendon or muscle transfer, which can be done by osteotomies and arthrodesis. If there is a residual limb length discrepancy, we can do the limb lengthenings by Elizarov technique or some other techniques, and very few people also do or need the patients need regarding the joint, particularly hinge knee joints and the hinge knee joints and hinge hip joints. If there is a correction or the pelvic correction of the pelvic obliquity, and the spine deformity also needs, and there needs stabilization as well. To start with the shoulder joint, before embarking to any procedure on a reconstructive procedure on the shoulder or any joint, you must know the principles of the surgery, understandings of the biomechanics, assessment of the paralyzed muscles, and available substitutes. To details, if you go, the Saha in 1967 has given a very nice classification of biomechanics of the muscles acting on the shoulder joint. He classified the muscles in the primers, steering groups, and the depressor group. In the primers groups, it is very commonly and more important muscles are the deltoid muscle and the pectoralis major muscle. They are bulky, they act on the long lever arm, especially the clavicular head exert a major force for the abduction of the shoulder joint. Then since this is the ball and socket joint, it needs an steering group which mobilize or rotate the muscles and stabilize as well. This steering group includes the superior steerer, horizontal anterior, and horizontal posterior screw. They are the muscle that is called supraspinatus, subscapularis, infraspinatus, teres major muscles. By virtue of their insertion near the articular surface, near the joint, and they exert a good activity on the neck shaft angle. They steer the head on the glenoid surfaces. They also exert an stabilizing force, but they have a limited abduction force or lifting the arm. Then there is a depressor group, which is also called as the intermediate group, which includes the pectoralis major and pectoralis minor and external head pectoral major, latissimus dorsi, and the pectoralis minor as well. These rotates the humeral head during elevation and depress the head towards the later part of the movement. They also act as a weak steering muscles. Saha also explained the pattern of the paralysis in upper limb. He classified these in the group 5 groups depending on the severity of the paralysis and number of joints involved. Muscles involved are paralyzed mostly if there is in the type 1 is the serratus anterior, levator scapulae, rhomboids, and trapezius and deltoid. When these muscles are involved of paralysis, there may not be the dislocation or subluxation of the shoulder joint. But when there is a deltoid anterior and mid-part rotators are involved, but other griddle muscles remain normal, there may or may not be the subluxation of the shoulder joint. But when there is a type 2 paralysis and there is an elbow flexor paralysis and supinator palsy, often there may be a joint subluxation of the shoulder joint. But in part 4, there is a partial paralysis of trapezius, serratus, glenohumeral muscles and the muscles at the wrist and elbow joint. When these muscles, there is a significant paralysis of the muscles around the shoulder and the elbow joint, where is subluxation or dislocation of the shoulder joint. But in the type 5, there is complete loss of the muscle power around the shoulder joint and the upper limb as well in the forearm and maybe in the wrist and hand. The limb is flail here and the shoulder is usually dislocated in these type of pattern of dislocations. Here we can discuss the substitute for the paralysis, residual paralysis of the muscle. For the shoulder, I would say there is a trapezius muscles and the group of the superior muscle which are available, which can be transferred by the deltoid palsy. But when there is a supraspinatus paralysis, which is superior glider, substitute most commonly used is the levator scapulae, preferably due to same direction of the muscle forces and the fibers of the muscle length and the same length of the fibers. Some people also transfer sternocleidomastoid muscle, and rarely scalenus anterior medius and scalenus posterior muscle are also used for the supraspinatus paralysis, which produces initial 15 to 20 degree of shoulder abduction. Then if there is a subscapularis paralysis, it is anterior glider or anterior rotator muscle, then substitute available for this muscle paralysis are upper 2 digitation of serratus anterior. Sometimes pectoralis minor is also used, and the pectoralis major, whole of the pectoralis major can also be used for the subscapularis, which produce good flexion of the shoulder joint. The infraspinatus, when it is paralyzed, it is the posterior glider which acts from the behind. The posterior muscle, therefore, latissimus dorsi and teres major are substituted for the paralysis of infraspinatus. When there is a deltoid paralysis, you can transfer the muscle or tendons of the muscle, and the classical method for the transfer of the deltoid palsy is the Bateman transfer or Bateman trapezius transfer. When the single muscle transfer is used without any consideration to the function of the steering group. Sometimes there is a shoulder paralysis, complete paralysis, then we do the shoulder arthrodesis, particularly in subluxation and the complete paralysis of the shoulder. Here is the Bateman trapezius transfer. We give incision, curved incision around the shoulder and a vertical incision to produce roughness around at the lateral surface of the humerus. Trapezius muscles along with the acromion is splitted and transferred over the shaft of the humerus near to the area between the shoulder and the Bateman area, where you can place it with this muscle after creating a roughness on the humerus near the humeral head near the articular surface, and the fix this trapezius with the 3 or 2 small screws over the shaft of the humerus above the Bateman area. This is the trapezius transfer, which is called the Bateman trapezius transfer. Very good muscle to do the paralyzed, substitute the paralyzed deltoid. Saha also advised a transfer of the trapezius muscle, but total transfer of the trapezius muscle along with the clavicular part, acroboclavicular joint, and adjacent part of the spine. He also transferred at the same area above the Bateman area, between the area, the shoulder, the surgical neck, and the Bateman area on the lateral space of the shoulder, and then it acts for the good abductors and substitute also the rotators and the depressors as well. Then when there is a small or partial paralysis of the deltoid, the hormone transfer is commonly used. In the posterior part of deltoid is functioning, but there is a weakness of the middle and the posterior anterior part of the delta, which is paralyzed. The substituting part is the posterior functioning part of the deltoid, which is transferred over the atrophic deltoid head like this. This is the posterior deltoid part, which is shifted from the posterior part to over the anterior area, and it is stitched over the anterior part of the deltoid. Then it prevents the subluxation and dislocation of the shoulder joint, and also act as an abductor for the to substitute the partial palsy of the deltoid muscle. This is the shoulder arthrodesis. When you are doing the shoulder arthrodesis, there is a scapulothoracic motion which substitute the glenohumeral motion at the shoulder joint. And when you are doing the arthrodesis of the shoulder, one must know the primary prerequisites that is very important. Normal muscle motor strength must be in the trapezius, scapulothoracic movement, and the serratus anterior to have a good scapulothoracic movements. And also a good functioning hand is very important. If you do not have a good functioning hand, then what is the need for the arthrodesis? Because and sometimes there is a shoulder paralysis along with the flexor paralysis of the elbow joint, but good functioning hand. Then we need to substitute for the paralysis of the bicep or flexors of the elbow and arthrodesis of the shoulder joint to achieve a good movements as we will describe in the later portion. But best shoulder fusion should be done after epiphyseal closure. These are the positions which are most acceptable positions for the shoulder fusion. That is 60-degree abduction, 20-degree of flexion, and 25-degree of internal rotation. But some people advise in females 30-degree of abduction, 5 to 10-degree of flexion, and greater internal rotation because of their activity of hand and the combing of the hair and the anterior positions. Here, the lesser degree of abduction is compensated with the greater degree of internal rotation. There is a caution while you are doing the shoulder arthrodesis that shoulder should never be fused in external rotation because the limb will be positioned in awkward and functionally poor results will be there. Here is the position of the optimum position. With this optimum position, these gentlemen can do good eating purpose for reach we call, and the combing of the shoulders and cleaning of the back area. This is the splint which we before surgery we prepare and give for the 6 to 7 week post-operatively after shoulder fusion. The methods of the shoulder arthrodesis are well known. We can do intra-articular shoulder arthrodesis, extra-articular shoulder arthrodesis, which is commonly done in infected and tuberculous shoulder, but we do combination of about 2 intra and extra-articular arthrodesis, which may be with compression arthrodesis by 1 plate or 2 plates and screw to the femoral head to the glenoid. And by this method, we call the combination of the extra and intra-articular arthrodesis with the articular position. This is intra-articular arthrodesis has been done and with the simple screw fixation. And some people do arthroscopic arthrodesis by placing screws with the mini incisions through the arthroscope assistance. Here the different positions which they have achieved after good shoulder optimum position of arthrodesis. She can comb her hairs and reach can face, and the abduction they can do with the scapulothoracic movements. Then now comes to the elbow and the forearm paralysis. We will discuss the what muscle we shift or transfer for the paralysis to restore the elbow flexion. Common methods we use the Standler's flexoplasty, Kellerach's transfer of pectoralis major, Brook and Ziauddin transfer of the pectoral major with biceps tendon, and some people, the Bunnell has done the sternocleidomastoid muscle transfer, Cipra has done the pectoralis minor transfer, Bunnell and Carroll anterior transfer of the triceps tendon, and the Hovenius transfer of the latissimus dorsi. Few details we will discuss here. This is the flexorplasty by Stiller method. The common origin of the flexor is detached from the medial epicondyle and the medial condyle. With the graft, it is extended and transmuscular tendon insertion attachment is done supraacetabular area in the anterior shoulder, anterior humerus. That is called Standler's Standler process, and modification because of this correction, it is called the Bunnell's modification. It is called flexoplasty. Then there is anterior transfer of the triceps, that is called Bunnell and the Carroll transfer. With extended with the graft, the tricep is rotated and fixed on the biceps insertion, previous biceps incision, the bicep tuberosity here. And this is again a flexoplasty. Then the Brooks and Ziauddin transfer, which is common, which is very lone procedure. Here we detach the biceps tendon from the superior attachment and also detach the pectoralis major from the sulcus, and then pass this tendon looped through the pectoralis major and reinsert with the distal part of the biceps tendon. So the pectoralis major then acts as the flexor of the elbow joint. Very common procedure we used to do in 90s when we have a significant cases of the poliomyelitis residual paralysis. Here is the Hovenian transfer of the latissimus dorsi. A big incision is given to detach the latissimus dorsi and to bring it anteriorly and then attach to the biceps tendon to have the flexor movement with the latissimus dorsi transfer. Then there is a posterior deltoid transfer to restore the tricep paralysis, that is called elbow extension paralysis or loss of the extension of the elbow joint. We transfer triceps paralysis. In the triceps paralysis, substitute with the posterior part of the deltoid muscle, and the procedure's name is the Momberg's procedure. Then there is a supinator deformity because of loss of the pronators. When there is a loss of pronators, we use the supinator. It's the supinator biceps muscle, which is attached on the bicep tuberosity on the radius. We detach it from here with the Z-plasty, and then it rotates from externally, laterally again to the medial surface and reattach with the biceps, and then it acts as the pronator. So that is called restoration of pronation power with the biceps muscle, and the supinator deformities go away. Now the hand and wrist deformities. In hand, again, there is some pattern of the paralysis. Pattern 1 paralysis is the weak and paralyzed opposition and abduction of the thumb, where the flexors of the long flexors and long extensors of the finger are normal. Here, finger, in addition to that, there is a weakness of intrinsic muscles for the finger, but long flexor extensors are normal, and the wrist extensor and the flexors are normal. Type 2 paralysis, there is a paralysis of intrinsic muscle for the fingers, the weak long flexors, and there is also paralysis of the opposition and the thumb. Here, the paralysis of the fingers, in the finger, there is a paralysis of intrinsic muscles. Long extensor and extensors are weak, but there is a weak paralysis or normal elbow wrist flexor, especially the flexor carpi ulnar is normal to give a good flexion power at the wrist joint. Then third pattern is complete paralysis of the thumb muscles except grade 1 and power to grade 1 to 2 power in the long flexors and extensors. There is a paralysis of intrinsic muscles for the fingers and the partially functioning long extensors that may be a grade 2 to 3 powers, give or grade 1 to 2 powers, and the decline of the fingers there is. And also, since there is a significant paralysis of the long flexor and extensor, there is a wrist drop as well. So surgeries here again, this is same pattern for the hand. Here is patient which shows the type 1 paralysis. There is a thenar paralysis, muscles paralysis, and there is no opposition and abduction of the thumb joint. Here is the type 2 paralysis. The long flexors are broken nearly, but there is a thenar paralysis with the weak thumb and long flexors and long paralyzed intrinsic muscles produce the decline of the fingers. So deformities in wrist and the hand can be flexion and ulnar deviation of wrist with or without contracture, flexion contracture, wrist contracture. There may be a volar subluxation of mid-carpal articulation contributing to the above deformity. There may be a thumb wave contractures and trapezio-metacarpal joint contractures. So before embarking to any surgery or tendon transfer, you must correct these contracture and deformities before transfers. The reconstruction surgery for type 1 arter pattern, when there is a opponent's weakness, this is called the eponomplasty. You can use the flexor digitorum sublimus of the ring fingers for the opponent's plasty. You can use extensor carpi ulnaris for the opponent's plasty. Most commonly, the palmaris longus is used for the opponent plasty. There may be hypothenar muscle paralysis, and the transfer for this is abductor digiti minimi. Here it shows the extensor indicis opponent's plasty is done if the extensor indicis at least 4 grade or the palmus longus is transferred, rerouted distal to the extensor and distal part to the extensor pollicis superficial tendon, and alternative in the pattern 1 can be for the paralysis for the finger intrinsic to correct the finger clawing is the palmaris longus, extensor carpi radialis longus, extensor carpi radialis brevis muscles. Here it shows there is abduction and the opponent's weakness, and it has been corrected by the flexor digitorum superficialis tendon transfer from ring finger to for the abduction and opponents. Then stage 1 in the pattern 3 paralysis particularly, it is done in stage wise. For thenar muscle paralysis, the trapezio-metacarpal arthrodesis of intra-metacarpal bone grafting procedure is done to maintain the thumb in the fixed palmar abduction. For weak finger intrinsic or clawing, volar capsulodesis is done at the same stage, followed by 3 weeks plaster cast and then stage 2 surgery to improve the flexion of the finger and the thumb, and flexor digitorum pollicis transfers, flexor digitorum profundus transfer or stage or tenodes to each other at the distal forearm so that whatever available flexion power is there can be evenly distributed. Stage 3 surgery is particularly for the wrist drop, where we can transfer the muscle that is called extensor carpi radialis brevis or flexor carpi ulnaris or flexor carpi radialis in combination with the extensor digitorum communis and the extensor pollicis longus for the flexors. Or sometimes we do the arthrodesis of the wrist joint. These are the references which I have followed, and Benjamin Joseph Postly, it is taken from the Campbell's Operative Orthopedics 12th edition and multiple literature, my own publications as well. To go briefly as the summary, Saha has classified muscles as the prime movers, steering group, and the depressor group. And then there is a muscle paralysis around the shoulder joint with dislocations. In type 1, type 2, and type 3 paralysis, there is the mild paralysis. There may not be subluxation of the shoulder joint. In type 4 particularly, there is a significant paralysis of the trapezius and glenohumeral muscles, so dislocation may be there. And type 5 pattern is the paralysis of the shoulder joint with the flex shoulder joint. These are the muscles which can be transferred by the supraspinatus. The levator scapularis is commonly transferred. For subscapularis, the upper digitation of serratus anterior or the pectoralis minor is transferred. For spinatus, infraspinatus, latissimus dorsi, and the teres major can be transferred. For the deltoid paralysis, most common procedure is the trapezius transfer. And when there is a filial shoulder, there is arthrodesis of the shoulder. Here is the trapezius transfer from acromion to the shaft of humerus laterally above the Bateman's area. Then there is also Sahas transfer of trapezius, which we transfer with the clavicular and AC joint and the acromion part of the scapular spine, and all are transferred to the lateral part of the shoulder below the humerus. Then there is a hormones transfer of the partial deltoid palsy, where the functional posterior part is transferred to the over the anterior part to prevent the subluxation. Then there is a shoulder arthrodesis, which can be of three types: intraarticular, extraarticular, and the combined extraarticular and intraarticular. When you do the shoulder arthrodesis, there should be a good scapular thoracic motion is to be restored, but there is prerequisites. Prerequisites are normal motor strength of the trapezius and the serratus anterior, which they can lift the muscles, and the normal functioning hand. If the functioning hand is not normal functioning hand, there is no need to transfer. Then optimum position of the shoulder arthrodesis, commonly it is the 50-degree abduction, 20-degree flexion, and 25-degree internal rotation, and these are the positions and the actions after the shoulder arthrodesis. Common procedure is the combination of the two intra and extra-articular arthrodesis. These are the position and the function after arthrodesis. Then there is the elbow and the forearm paralysis. And to substitute the flexor weakness, we mostly do the external flexoplasty or Brooksman and the transfer of the pectoralis major. And this is the example of the external flexoplasty of the common origin of flexor transfer to the shaft of the humerus, and the triceps transfer to the biceps tendon, and they act for the flexor of the elbow joint. Here is the Brooksman and Ziauddin transfer, where the biceps tendon is detached superiorly through the detached portion of the pectoralis major. It is reinserted, and pectoralis major acts as the flexor of the elbow joint. Ovenian transfer is mostly latissimus dorsi transfer for the flexor muscle of the elbow joint. Here, sometimes there is an elbow extensor paralysis or weakness, that is the tricep paralysis. You can use the posterior deltoid muscle like this, posterior deltoid muscle that is called Momberg procedure. Sometimes there is fifth supinator deformity, and this supinator deformity can be corrected by restoration of the portion by transfer, rerouting the biceps from lateral to the medial, and this acts as a good pronators. Wrist and hand deformities and weakness, again there is a pattern of the paralysis. In pattern 1, there is a opponents and the abduction paralysis, weak intrinsic paralysis, and the wrist is normal. In type 2, there is a significant paralysis of the opponents and the thenar muscles, and the partial paralysis of intrinsic muscles. Therefore, there is a clawing of the toes or the clawing of the fingers. Then there is a third group, is the complete paralysis of the thumb thenar muscles, and the partial or the complete paralysis of the long flexors, and there may be a wrist drop. Treatment is complex for this, and that has been already advised. If there is a opponent's paralysis of the thumb abductor paralysis, we do the opponent's transfer. When there is a significant class type 2 paralysis with the paralysis of the intrinsics of the thumb, and then there must be release of the contracture. There may be a contractures and ulnar deviation at the wrist joint, volar contracture, trapeziometaboid contractures. These contractures must be released before tendon transfers. Here is the transfers for the opponents. Activity that is called the flexor digitorum of sublimus of ring, or the palmaris longus is commonly done for the opponent's plasty. But there is a hypothenar paralysis, abductor digiti minimi can be transferred to restore the power, a little bit power at the hypothenar muscles. Here is the paralyzed intrinsic muscles, clawing of the finger, they can be restored with the palmaris longa or extensor carpi radialis longus muscle or extensor carpi radialis viris, and extensor index is used for the opponent's plasty. This example shows the weakness of the extensor abductors of the thumb, and after transfer of the subliqumus tendon, there is a good pinch at the and good power at the thumb. So when there is a pattern 3 paralysis, there is a stage-wise treatment. In the early stage, you need to transfer the arthrodesis of the trapeziometaboid transfers, finger intrinsic and volar capsulodesis. Then second stage surgery for transfers of the flexor digitorum profundus slips for the fingers. And in third stage, you do the wrist arthrodesis. You can have this lecture on the slide share and also in the YouTube and on the Facebook of the Pediatric Orthopedics and Clubfoot Clinics, which is managed by me. You can also have this lecture through my email address, but it will be available on the slide share. And next week, inshallah, will be available on the YouTube after editing. I think I'm very thankful to the Professor Suhail Rafi, Professor Nadeem Baloj, my faculty and residents and the participant as well. Little bit, it was dry. There was a little bit hesitation in between, but I think in nutshell, it was a little bit better. Inshallah, when you read in detail through the slide share and listen lecture again, you can understand and you can go through your examinations. Thank you very much.